Good morning. My name is Amir Darki. I'm a cardiologist at Loyola University Medical Center. I want to thank Dr. Tafour and Dr. Walengo for the kind invitation and looking forward to a fantastic symposium. I've been charged with unraveling why pulmonary embolism mortality reduction is elusive and the role of pulmonary embolism response teams. So our goals today is to have a background of pulmonary embolism and classification. I want to discuss PE trials specifically related to submassive cohorts. We want to address the question, is mortality the correct metric, and look at some novel risk predictors. And we'll conclude with the role of pulmonary embolism response teams or PERT. As this audience well knows, PE represents the third leading cause of cardiovascular mortality, affecting 300 to 600 individuals yearly, with an annual mortality between 100,000 to 180,000 people. The initial presentation influences morbidity and mortality and dictates choice of therapy. Mortality can exceed 58% in patients presenting with post-obstructive shock. Over the last 20 years or so, the incidence rate of pulmonary embolism diagnosis has increased, due in part to better technology to detect PE. Over the same time period, the overall case fatality rate has gone down. We typically classify pulmonary embolism into low, intermediate, or submassive or high-risk PE, or what we call massive PE. High-risk PE is shock or hemodynamic compromise, as defined as a systolic blood pressure less than 90 for 15 minutes or longer. Fortunately, it encompasses about 5% of all PE cases, but it's associated with the highest inpatient mortality. The treatment is you have to break the spiral of deterioration either with systemic or catheter-based TPA or surgical approach. Intermediate risk PE, these patients are hemodynamically stable, but they have signs of RV dysfunction on CT or echo or elevations of biomarkers. This compromises about 30% of all PE cases. It's a very heterogeneous group. It's associated with increased mortality, but the treatment remains unclear. Low-risk PE, these patients have no hypotension or elevation in biomarkers. They have a normal RV and are candidates for early discharge outpatient management. Let's look at the trials. So in the 60s and 70s, the pulmonary embolism space had trials with fractionated heparin, and ultimately it went to urokinase and streptokinase. In the 80s and 90s, TPA looked at massive PE. The Sanchez trials had 4 patients. The 4 that got thrombolytics survived, the 4 that did not deceased, and the trial was stopped. In the early 2000s, the cohort of submassive patients was examined. The PITO trial, to quote Dr. Goldhaber, is a fantastic, marvelous trial. It was a multi-center, double-blinded, randomized controlled trial of 76 sites in 13 countries. They were looking at the efficacy of tenecteplase plus heparin versus placebo plus heparin alone in treating intermediate risk submassive PE. There was about 500 patients in each arm. Inclusion criteria are patients who had RV dysfunction and myocardial injury with troponin elevations. The primary outcome included death or hemodynamic compromise within 7 days. The primary safety outcome was major extracranial hemorrhage or ischemic or hemorrhagic stroke within 7 days. The hemodynamic decompensation definition for the primary outcome becomes very relevant, and it was defined in the trial by CPR, systolic blood pressure less than 90, for greater or equal to 15 minutes, a drop in systolic blood pressure greater than 40 for greater than 15 minutes, with findings of end organ hyperperfusion or need for pressors. So the primary endpoint favored tenecteplase, but it was driven largely by hemodynamic compromise. The mortality was not statistically different between the 2 arms. The safety endpoint favored the placebo. TPA had a significant major extracranial bleeding rate of 6.3% and a hemorrhagic rate of 2%. The forest plot here, as you can see, the primary endpoint favored the TPA, where the safety endpoint favored placebo. Ultimately, the study authors concluded that in intermediate risk or submassive pulmonary embolism population, it's clear that full-dose systemic lytics cannot be recommended as routine primary treatment. even if signs of RV dysfunction or myocardial injury are present. So, as opposed to the 100 milligrams of TPA, which was used in this study, they suggested an alternative approach with smaller doses. In a long-term follow-up of this study, published in 2017, there remained no difference in death between TPA versus placebo. What's interesting about the trial is approximately 33% of patients reported some degree of persistent functional limitation after intermediate risk PE. The CTEPH population, however, was low, 2 to 3%. You can see the Kaplan-Meier curves extending with no difference. So what we've learned is that the traditional classification using submassive PE mortality hampers the clinical trials as the short-term mortality is low. So perhaps using novel metrics may be a pathway to getting more granular information. To examine this, let's go to the pathophysiology. So we know that acute PE interferes with both gas and oxygen change in circulation. People die from PE because the RV fails. We know the RV output is the LV inflow, so if the RV fails, the LV is underfilled and they enter the spiral of death, which frequently is difficult to break. Outcomes in PE is a function of both embolus size and underlying cardiopulmonary status. People with RV dysfunction have worse outcomes, but this is a heterogeneous group and difficult to determine. We have to look beyond the anatomic definition. So we know patients with high-risk massive PE benefit from lytics, and we know that low risk can be discharged early or directly from the ER. The holy grail, however, is those that lie in this gray box, and trying to determine that likely will be the solution in this population. So in an effort to tease this out, there's been different efforts made. In the imaging population, Doppler echocardiogram, strain imaging has been used in acute PE, RVOT, the aortic ratio has been used. Our group looked at RV stroke volume by pulse wave interrogation of the pulmonic valve. In ROC curves, we determined a 9.5 centimeter to be predictive of cardiac index less than 2.2. In our Kaplan-Meier curve analysis, demonstrated an association with worse outcomes. Functional assessment is another strategy. In a very elegant study done in Canada, 100 acute patients had CPET at 1 month and 12 months, with the primary endpoint being a decrease in 80% predicted max VO2. At 1 year, 46.5% of patients, so almost half, met the primary endpoint of some functional limitation. These was associated with significantly worse health-related quality of life scores, dyspnea scores, and reduced 6-minute walk tests. Biomarker data. So we know that troponin has been associated with severity of pulmonary embolism. The Sam Goldhaber group looked at 1,000 patients in the ICOPA registry, International Cooperative Pulmonary Embolism Registry, and found a significantly higher incidence of mortality at 30 days in those with RV dysfunction in the normotensive population. Bacanti in the Italian study added to that with biomarkers of troponin and had an additive effect. So, in an effort to tailor treatment modalities, Dr. Farid in the hemostasis and thrombosis lab at Loyola has been looking at biomarkers, trying to understand the complex interplay of activators of fibrinolysis versus circulating inhibitors such as PI1, TAFI, and A2A. We know this is a heterogeneous population, but perhaps understanding this phenotypic map will allow us to tailor therapies. So his lab has demonstrated that those with massive PE have a higher PI1, lower TAFI, lower A2A. And these have been correlated with RV-LV ratios, TAPSE, and RVOT-BTI. In phenotypic mapping, certain subsets had worse outcome based on these biomarkers. I'd like to conclude with the role of the pulmonary embolism team. Because the decision to administer thrombolysis is fraught with difficulty, having a multidisciplinary team of experts allows the group to quickly manage many of the issues that present with patients who present both acutely with PE and long-term management. Building a PERT team starts with a leader and having consultants available via either a paging system or a video conferencing. The Loyola PERT team, we're fortunate to have multiple specialists, including pulmonary critical care, CV surgery, IR, hematology, the ER pharmacy, vascular surgery. So in summary, pulmonary embolism is a fascinating but at times frustrating disease process. Mortality is not an ideal metric, and looking at novel markers such as imaging, functional assessment, and biomarkers may be the holy grail. Pulmonary embolism response team can aid in acute and long-term management of PE. Thank you very much for your time.